Bismillahirrahmanirrahim. Today we are going to discuss a very important topic in relation to the inflammation, and the topic is the systemic effects of inflammation. The systemic effects of inflammation is very important because a sound knowledge and understanding of the different signs, symptoms, their underlying mechanisms, and the different pathological and clinical effects that result from inflammatory response. We know that inflammation is a defense mechanism, and it is the response of the body, mainly the immune system, to foreign invaders. So when we know that how the immune system and how the body respond and what are the effects that are produced in the body due to the result of the inflammatory process, and once if we know uh, the understanding and the underlying mechanism and the effects and events that occur because of the inflammatory process, we can make an easy understanding, and this understanding will provide very valuable tools that will help in the diagnostic approach of an inflammatory disease, in the assessment of the severity of inflammatory disease, and then the assessment of the response to the treatment. Now, what is acute phase response, which make the systemic effects of inflammation? The acute phase response or acute inflammatory response is the body's rapid attempt to restore homeostasis after tissue injury, infection, or sometimes some types of immune reaction. The clinical and pathologic changes that are associated with the acute response include fever that we commonly uh, see during an acute illness. For example, when a person suffers from respiratory tract infection, when a patient suffers from malaria, from dengue fever, and so many other diseases that can cause fever. So today we will discuss that how fever is caused. The second component of the acute phase response are the elevated plasma level of acute phase proteins. Acute phase proteins, they are very important, and they result from the action of the inflammatory cells on different body organs like the liver, brain, bone marrow, and the outcomes or an understanding of the outcomes is very important for us to reach a diagnosis and to guide therapy. The third component of the acute phase response is the leukocytosis. By leukocytosis, we mean increased number of leukocytes in the circulation. We know that the leukocytes are the granulocytes that include neutrophils, eosinophils, basophils, and mast cells, and the agranulocytes, that cells that do not have granules in their cytoplasm. The agranulocytes include lymphocytes, which are further divided into small lymphocytes, large lymphocytes, the monocyte, macrophages, and dendritic cells. So these three, the fewer acute phase proteins and increased number of leukocytes or leukocytosis, these are the major components of the acute phase response. Additionally, there may be increased heart rate and high blood pressure with other manifestations like rigors and chills that we commonly see in high-grade fevers like malaria, pyelonephritis, and acute tonsillitis. Automatically, a patient with a febrile illness suffers from anorexia, which is loss of appetite, somnolence, he appears sleepy, and malaise. The patient appears tired and feeling uneasy. Now, we know that the causative agent, which may be in the form of microorganisms like bacteria, viruses, fungi, parasites, what happens that these organisms have mechanisms and they activate the inflammatory cells. Once the inflammatory cells are activated, these activated inflammatory cells, they will release cytokines, and these are these cytokines that are responsible for the acute phase reaction or systemic inflammatory response. Now, these cytokines act on various body organs and systems and produce pathological effects. And these pathological effects, they will cause the clinical events in the form of signs and symptoms. The pathological effects are most commonly measured in the pathology lab. It depends on our target of investigation. If we are investigating an infection, if we are, then we search for the bacteria and use various microbiological tools to identify the bacteria. If we are dealing with an immune reaction or sometimes viral infection, we may use certain serological tests. And how do we know the increased leukocyte count? By measuring the count of different leukocytes, for example, as I told, granulocytes, agranulocytes, and different diseases are characterized by changes in the count of the different cells. For example, neutrophil leukocytosis, it is a common feature that is seen in acute bacterial infection. Similarly, in chronic infections, the major cells are the lymphocytes, plasma cells, monocytes, macrophages, and also we look for the symptoms that result from these pathological effects, from the pathological effects of the cytokines released by the inflammatory cells on different body organs. Now, the three major components of acute phase reaction, they are caused by three major cytokines. Other cytokines may also be involved, but the major cytokines that are responsible for the acute phase reaction are the tumor necrotic factor, interleukin 1, and interleukin 6. I said that in different situations, other cytokines may also be involved, but the major cytokines are these three: tumor necrotic factor, interleukin 1, and interleukin 6. Now, what happens that these cytokines, they act on the cells in different organs. For example, fever, which is a common symptom seen in acute inflammatory conditions, particularly bacterial infections, it is induced by the resetting of the thermoregulatory center in the hypothalamus in the brain. So here the cytokines, they act on the brain. Similarly, the cytokines act on the liver and cause the liver to increase the synthesis of acute phase proteins. And the three acute phase proteins are the C-reactive protein, serum amyloid A, and fibrinogen. And here it is important to mention that normally in a healthy person, there is a reference range for the acute phase proteins as well as for the leukocyte count, and this is the change in the level of the acute phase proteins and the count of the leukocytes. For example, leukocytosis in the form of neutrophil leukocytosis that will occur in bacterial infection. In chronic infection, lymphocytes count will be increased. In parasitic infections, we know they, and also in allergic or hypersensitivity like situations, they will cause an increase in the count of the eosinophils. Now, first of all, we discuss the fever, how the fever is caused. So, bacterial products, for example, lipopolysaccharides and certain bacterial proteins, they can cause fever and therefore they are known as the exogenous pyrogens. But the exogenous pyrogens, how do they cause fever? That these exogenous pyrogens, they activate certain leukocytes, inflammatory cells, and these activated leukocytes will release cytokines, tumor necrotic factor, interleukin 1, and also interleukin 6. Now, how these cytokines cause fever? We know that the arachidonic acid metabolite pathway is a major concern in inflammation, in which what happens that the arachidonic acid, which is derived from the membrane phospholipids, is broken down into various metabolites. And here the arachidonic acid is acted upon by the uh, two enzymes mainly. One is the cyclooxygenase, and that is known as the cyclooxygenase pathway, and the other is the enzyme lipooxygenase, that is the lipooxygenase pathway. The lipooxygenase pathway will result in the production of leukotrienes and lipoxins. But here, since we are discussing the fever, so we will focus on the cyclooxygenase enzyme. The cyclooxygenase enzyme is responsible for the cyclooxygenase pathway, and the cyclooxygenase enzymes present in various inflammatory cells and other cells, it will convert arachidonic acid into its metabolites. And the major metabolites of the cyclooxygenase pathway are the prostaglandins and the thromboxane A. Prostaglandins that are produced in the neutrophils, while thromboxane A is mainly produced in the platelets, and it has got its role in hemostasis and coagulative disorders. Now, the cyclooxygenase enzyme, it will convert arachidonic acid into prostaglandins and thromboxane A. Now, the prostaglandins, the different prostaglandins that are produced by the action of the cyclooxygenase enzyme on the arachidonic acid include the prostaglandin E2. There are different prostaglandins like PGE2, PGI2. So, here the prostaglandin PGE2, it will cause the hypothalamus to release various neurotransmitters. And the PGE2 prostaglandin is mainly produced in the vascular and perivascular cells in the hypothalamus. We know that our body temperature is normally controlled by the thermoregulatory center, which is situated in the hypothalamus located in the brain. And this thermoregulatory center controls the temperature of our body at a defined range, and that is known as the set point. Normally, the temperature of a normal healthy person is about 37 degrees centigrade, or it may be 97.4 degree Fahrenheit, and it will not change so rapidly in response to the external environment. And this is very important and vital role of the hypothalamus brain and temperature regulator temperature regulating center for the survival. Now, what happens in infections, particularly the bacterial infections, that the prostaglandins, and especially the prostaglandin E2, which is produced by the action of the cyclooxygenase enzyme in the vascular and perivascular cells situated in the hypothalamus and the arachidonic acid. So the PGE2, which results from the arachidonic acid uh, metabolites and the cyclooxygenase pathway, it will cause the hypothalamus to release certain neurotransmitters. And these neurotransmitters during a bacterial infection are fewer. It will change the set point of the thermoregulatory center. And this set point is changed from the normal set point to a set point with a higher level. And we know that the person in acute infections, for example, malaria, tonsillitis, pyelonephritis, dengue fever, and other conditions, he may be having 104 up to 104 degree Fahrenheit temperature. So this is the mechanism that how fever develops in a patient who suffers from infection. The second important component of the acute phase proteins or acute phase reaction include the elevated level of the acute phase proteins. There are three acute phase proteins, the major ones. One is the C-reactive protein, the other is the serum amylase ARSAA simply, and the third is the fibrinogen. I said that normally these three acute phase proteins, they are present, but they they have a certain defined range, and that defined range has beneficial effects, but if the acute phase proteins remain in their defined range, they will have their beneficial roles, but they will not cause damage to the body. Now, in inflammation, what happens that particularly the interleukin 1 and interleukin 6, these cytokines are released by the inflammatory cells and other cells in response to an infection or inflammation, and they will act on the liver, which is the major metabolic machinery of the body. Now, when the interleukin 1 and interleukin 6 act on the liver, they will cause increased production of acute phase proteins. The normal range for C-reactive protein, particularly the high specificity C-reactive protein, should be less than 1 milligram per deciliter. By highly specific C-reactive protein measurement, we mean that the normal lab procedures can measure the level down to 3 milligrams per liter. But by using the technique with high specificity C-reactive protein, we can measure even the level below 1 milligram per deciliter. And if it is below 1 milligram per liter, it is physiological. But if the level of the C-reactive protein is increased, it will indicate an inflammatory reaction in the body. And here one thing very important that I want to mention, that normally certain diseases like blood pressure, diabetes mellitus, we consider them not to be of any inflammatory origin. But it is true that mild type of inflammation is involved in even in these apparently non-infective looking diseases. For example, the atherosclerosis, which is involved in myocardial infarction and cerebral strokes, and which is also involved in hypertension, is actually, it takes a start from an inflammation, and therefore measuring the low level measurements of the highly specific C-reactive protein. Now it is commonly done in evaluating the person status in relation to diabetes mellitus, hypertension, and other diseases. Because actually atherosclerosis starts from inflammation. There is inflammation which results in endothelial injury, and the endothelial injury will start the process of atherosclerosis. And we all know that atherosclerosis is responsible for hypertension and cerebrovascular accidents, myocardial infarctions, and peripheral vascular diseases. But here in inflammation, the C-reactive protein and serum amyloid A, what is their role in inflammation? They act as opsonins, complement fixation. These acute phase proteins bind to the bacterium, and normally our immune cells, particularly the phagocytes, they do not recognize the bacterium, but they do recognize the bacterium by certain means, and one way is the opsonization. So the C-reactive protein and serum amyloid A, they bind to the bacterial wall, and this is a red flag for the phagocytes. Now the phagocytes will identify those microorganisms, they will attack them and will kill them by phagocytosis. Now coming to the fibrinogen, we know that the erythrocyte sedimentation rate, which is a common test in baseline investigations of a disease. Now what is ESR? Yani sedimentation of erythrocytes. Now normally the ESR, it should not be more than 20 in a person maximum. But during inflammation, when there is increased synthesis of fibrinogen, what happens that this fibrinogen, it's like a glue, and it stick red blood cells to each other, and automatically the clump of red blood cells, it will sediment uh, quickly as compared to the uh, individual red blood cells. So the excess production of fibrinogen, it will increase the erythrocyte sedimentation rate that we commonly do by using the ESR tube or Sturgeon's tube. And the underlying mechanism here in the increased erythrocyte sedimentation is the excess production of fibrinogen by the liver in response to the interleukin 1 and 6 that is produced by inflammatory and other cells in response to infection or some type of immune reaction. So the acute phase proteins that make the second most important component of the acute phase reaction after fever, which is number one, the acute phase proteins, they are the second, make the second component of the acute phase protein, and the acute phase proteins are the C-reactive proteins, serum amyloid, and fibrinogen. Now, clinical laboratory uses of acute phase proteins. As I said, that these are very important, and they help us to make the diagnosis and to uh, uh, see the response of the patient to the treatment. So we can say that the serial measurements of ESR and CRP are used to assess therapeutic responses, the severity of the illness in patients with inflammatory diseases, for example, in rheumatoid arthritis. Rheumatoid arthritis is a common immune mediated disease of the joints, but it is also associated with an increased ESR and the C-reactive proteins. And serial measurements of these components may help us to assess the severity of the disease as well as the response of the patient to the treatment. As I said, that fibrinogen binds to red blood cells and cause them to form stakes, which is known as the rouleau formation. And automatically, a group of red blood cells in the form of rouleau formation, that will sediment more rapidly than when the erythrocytes are individual, separated from each other. The elevated serum level of C-reactive protein is used as a marker for increased risk of myocardial infarction or stroke in patients with atherosclerotic vascular disease. And as I said, that inflammation is involved in the development of atherosclerosis. And increased C-reactive protein level is a measure of inflammation. I told you that actually the atherosclerosis start from the vascular injury. Once the vascular injury occurs, then the circulating monocytes are modified into macrophages, and these macrophages, they come and accumulate at the site of the endothelial injury, and then the low density lipoproteins play their roles and give rise to the accumulation of fat, which is engulfed by the macrophages, forming the foam cells. And so from this discussion we conclude that atherosclerosis actually starts from endothelial injury, and it takes start from an inflammatory reaction, and later on it will give rise to the very serious and sometimes fatal complications. Now, the third component, the number one component was fever. The second component was acute phase proteins. And acute phase proteins, the major proteins are the C-reactive protein, serum amylase A, and fibrinogen. But the third component of the acute phase reaction is the leukocytosis. And by leukocytosis, we mean increased number of leukocyte count. And again, here we use the pathology lab to measure the leukocytes, and it provides us an important parameter of the inflammatory response. Now, what is the underlying mechanism? That inflammation results in the production of cytokines, and these cytokines, they will increase the leukocyte production and the leukocyte level in the blood by two ways. In the acute phase, the cytokines, particularly the tumor necrotic factor and interleukin 1, they act on the bone marrow and cause the release of already resolved cells present in the bone marrow. In the chronic phase that commonly occur in chronic inflammatory response, what happens that here the colony stimulating factor, the cytokine colony stimulating factor, play its role in the chronic phase, and it not only increase the output of the leukocytes from the bone marrow into the blood, but it also stimulates the bone marrow to synthesize new leukocytes. So tumor necrotic factor and interleukin 1, they increase the leukocyte count in the plasma by increasing the release of preformed resolved cells that are present there. But in the chronic phase, the colony stimulating factor increase the synthesis of new leukocytes by the bone marrow. So as a result of the acute phase or chronic phase, initiated and stimulated by tumor necrotic factor, interleukin 1, and colony stimulating factor, what will happen that there will be a rapid release of leukocytes into the blood from the bone marrow. So in this situation, we have both mature and immature cells. Normally in the blood we get mature cells and a very uh, uh, small number of immature cells are present. But during the inflammatory reactions, the both the mature and mature cells are released into the blood. And since we know that the maturity starts from the premature cells on the extreme left side, and as it moves to the right, the cells become mature. So the cells, they get very little time to become mature, resulting in the increased number of immature cells in the blood. And this is known as a shift to the left. This is a normal picture of the uh, blood count, known as the complete blood count, and which is a baseline investigation and a very common test. And here we see that normally the WBC, they are 4,000 to 11,000 per cubic millimeter. And here in this test are also included the platelets, thrombocytes with their normal range. And we all know that decreased platelet count or thrombocytopenia is a very dangerous and serious situation in a disease. And we all know, particularly in dengue fever and many other diseases, that result in thrombocytopenia and can have even fatal outcomes and complications. Commonly, the neutrophils, they are the major cells present in the blood, and their count is increased in acute infections and bacterial diseases. The lymphocytes, their count is increased in chronic inflammations. The eosinophils, they are cells that uh, are increased in allergic and hypersensitivity conditions and parasitic infections. And the role of the basophil is not very clear, and normally the ESR is it should be below 20 millimeter per hour. And increased ESR means increased production of the fibrinogen by the liver induced by the inflammatory cytokines, and it will occur in various acute and chronic diseases. So the final conclusion is that in leukocytosis, the normal leukocyte count, which is 4,000 to 11,500 cells per milliliter, they will increase up to 15,000 to 20,000. And this will indicate uh, an infection, a bacterial infection, and an inflammatory process. But in some situations, the leukocyte count is increased very, very high. For example, 40,000 to 100,000. And this situation will look like similar to the condition and situation seen in uh, blood cancer like leukemia. And for this reason, uh, so a high increase in the leukocyte count is known as the leukemia reaction, because it occurs uh, mostly in cancerous conditions. And the leukemia reaction, in which the leukocyte count is increased very high, and it looks similar to the picture that we see in leukemia. Most bacterial infections, they will cause neutrophil leukocytosis. Chronic infections and uh, diseases like uh, mumps, which is a viral infection of the salivary gland, particularly the parotid gland, the measles, and infectious mononucleosis, they will cause elevated lymphocyte count in the form of lymphocytosis. And the allergic and hypersensitivity related conditions like bronchial asthma and hay fever, the common influenza, and parasitic infection, they will cause increase in the eosinophils, which is the granulocyte. So certain infections, paradoxically, there are certain diseases that will cause a decreased neutrophil count. And these diseases that cause leukopenia, decreased leukocyte count. So the important diseases are the typhoid fever, and particularly nowadays the very well-known global pandemic, the COVID-19. It will also cause decreased leukocyte count and leukopenia. And leukopenia is also caused by the rickettsia and certain protozoa. And the mechanism behind the leukopenia or decreased leukocyte count that uh, we see in these diseases is due to the sequestration of the lymphocytes in the lymph nodes and uh, other organs. The final conclusion is that the major components of the acute phase protein are the fever, acute phase proteins, which are C-reactive protein, serum amyloid A, and fibrinogen, and the leukocytosis. And the leukocytosis may be neutrophil leukocytosis or it may be lymphocytosis, and sometimes even leukopenia, decreased cells count. So we see that the acute phase reaction is mainly run over by the three cytokines, inflammatory cytokines, the tumor necrotic factor, interleukin 1, and interleukin 6. So, by making a summary, fever is caused by the pyrogens, and these pyrogens induce the release of neurotransmitters in the hypothalamus, which make the thermoregulatory center to a high set point. The elevated level of acute phase proteins are the effects of due to the effects of cytokines on the liver. The increased leukocyte count or leukocytosis occurs due to the effect of the cytokines on the bone marrow, and other conditions like tachycardia or increased heart rate or increased blood pressure and decreased sweating are due to the redirection of the blood flow from the cutaneous to deep vascular beds. And the purpose of decreased sweating is to keep the body temperature normal and to reduce the heat loss. And usually we have seen that when we use the NSAIDs or like aspirin and other drugs, a person who suffers from fever, he has severe sweating. So the chills are rigors that are common with three diseases, for example, tonsillitis, acute tonsillitis, pyelonephritis, and malaria. But any disease may cause rigor and chills, and this occurs due to resetting of the temperature set point by the hypothalamus. The anorexia, loss of appetite, somnolence, and malaise, they are the secondary effects due to the action of the cytokines on the brain cells. And here I will mention that severe bacterial infections may cause high levels of the tumor necrotic factor, which may cause disseminated intravascular coagulations because tumor necrotic factor is also a thrombogenic cytokine. So, disseminated intravascular coagulation, consumption of the uh, platelets or thrombocytes, release of the histamine, excess histamine from the mast cells, and this type of situation like disseminated intravascular coagulation may lead to septic shock, which is one of the three types of shock: hypovolemic shock, hemorrhagic shock, septic shock, and shock caused uh, by a hypersensitivity reaction of the body to some foreign agent. But the most serious of the shocks is the septic shock, and this septic shock may be caused by severe bacterial infection, either localized or systemic, that will give rise to the very high levels of tumor necrotic factor. And tumor necrotic factor is a thrombogenic cytokine, and it will cause consumption of the thrombocytes, and also the uh, mast cells which are stimulated, and these cells, they release high levels of histamine, which is a strong vasodilator, and cause vasodilation and hypotension. And all this arrangement will give rise to the septic shock, which is a very serious condition and can be fatal if not treated on early basis. Thank you very much.